So now I'd like to welcome our next panel. Come on up while I say a few words and get situated here. So our next panel is New Data, New Opportunities for Diabetes Care, chaired by Matt Bouchonville, Medical Director of New Mexico's Endocrinology ECHO program. So come on up and have a seat, and we'll get you all started here in just a moment. Thank you very much.
All right, thank you, Leah, and thank you everybody for joining us today. I'm Matt Bouchonville, and I'm joined today by Nick Cuttress and Maggie McLean-McDonald, and we're here to discuss with you new data and new opportunities in diabetes care. Nick, would you like to introduce yourself?
Sure. Nick Cuttress, pediatric endocrinologist, global health professional by training, and founding director of the ECHO Diabetes Action Network.
Hello, Maggie McDonald, Director of Education for the Oregon Rural Practice-Based Research Network, located at Oregon Health and Science University, and I direct the Oregon ECHO Network.
Thank you, Nick. Thanks, Maggie. Thanks for sharing your insights with us today. And just a heads up to people, we are going to have some Q&A at the end, so please begin thinking about your questions now. We'd love to hear from you. And we'll start with some background. I'd like to kind of share the lay of the land in diabetes care before we get into discussion. And whether you're a diabetes care health professional or not, you're probably aware that diabetes care has really advanced significantly over the past 100 years. And in fact, it was 100 years ago this year that insulin became available commercially. And for a number of decades after that was really all we had. Prior to 1923, diabetes, especially autoimmune diabetes, was essentially a death sentence. We had no treatments. Decades later, we had an oral antihyperglycemic available, sulfonylurea medications. And then over the subsequent years, diabetes care became more complex. There was a greater emphasis on evidence-based medicine. And in the late 80s, we saw the ADA publish the Diabetes Standards of Care, Clinical Practice Guidelines for Diabetes Care. And this was a timely addition to the diabetes landscape because following the publication of the guidelines, diabetes care has really become exquisitely specialized. So we now have drugs that essentially work on every pathway of the pathophysiology involved in diabetes. So things like GLP-1 agonists, SGLT2 inhibitors, and so forth. Not to mention major advancements in recent years in diabetes technologies, things like artificial pancreas technology. And so this has really allowed us to individualize diabetes care. And independent of their glycemic lowering effects, a lot of these medications have been shown to independently protect the heart, protect the kidneys, and have, as such, have been adopted by clinical practice guidelines as first-line agents for patients at high risk for these complications. So how have these major advancements translated to diabetes outcomes in the real world? And sadly, what we're looking at here is hemoglobin A1C data, but hopefully you can get the feel that we're really not moving the dial at all when it comes to diabetes care quality outside of clinical trials. And there's multiple reasons for this. One of the major reasons is this idea of therapeutic inertia, this hesitancy to advance or intensify therapies for people with diabetes, in part because of the increasingly complex clinical practice guidelines. And so with diabetes, we have a chronic condition that is associated with multiple devastating complications, things like heart disease, kidney disease, cardiovascular death. And in most cases, these complications are completely preventable with effective treatment. But again, treatment has become exquisitely specialized, very complex, and we're not seeing these rapid advancements in diabetes care translating to real-world improvements in clinical outcomes. So there's a strong case to be made here for using ECHO for improving diabetes care. And I'm going to share some results that briefly show you that ECHO works very well for diabetes care we're going to start with our experience in New Mexico. We, about 10 years ago, launched an echo for diabetes. We call it EndoECHO. And we partnered with 10 federally qualified health centers in rural New Mexico and collaboratively recruited about 850 patients with complex diabetes. And this was defined as patients with autoimmune or type 1 diabetes, or they could be on insulin therapy or have a high hemoglobin A1C, greater than 9%. And we longitudinally tracked a number of cardiorenal risk factors, things like hemoglobin A1C, blood pressure, cholesterol, and urine microalbumin, which is a marker for kidney disease. Similarly, we looked at these same variables in a cohort of patients, about 150 patients, who were seen by us, a specialist at the diabetes clinic where I work at the referral center. And we compared these changes over time, over a period of about 18 months. And what we found is that the improvements in all of these risk factors in patients treated by echo-trained primary care providers, that the improvements were just as good as the improvements that were being experienced by patients at the diabetes specialty clinic. And in fact, in some regards, the patients in the echo cohort fared better. And what we're looking at on this slide is hemoglobin A1C data. And we're seeing here is that those in the echo cohort in rural New Mexico were more likely to transition than those patients in the specialty clinic from uncontrolled to no longer being uncontrolled, or from not being controlled to being controlled. These definitions are HEDIS measures, quality measure definitions. So the patients in rural New Mexico that are being treated by echo-trained providers are receiving care in the communities where they live by trusted providers. They're being activated, and we're seeing improved outcomes. When you improve a number of cardiorenal risk factors in patients with diabetes, you prevent complications of diabetes. And this can be huge from a health cost perspective. And in fact, our partners at Rutgers demonstrated that patients treated with diabetes, treated by echo-trained providers, echo-trained PCPs, experience significant reductions in healthcare costs compared to their peers who were treated by primary care providers not participating in echo. And this was primarily due to a reduction in inpatient hospitalizations. And so what we're seeing is that echo works. It improves clinical outcomes for diabetes. It's associated with reduced healthcare costs. And more diabetes specialists are recognizing this. And we're starting to see adoption of EndoECHO and new diabetes echoes across the nation, primarily in the United States, but we're also seeing this globally. And we are working together as well. Nick will be talking to us in a moment about the Echo Diabetes Action Network, but we're starting to use shared metrics, harmonized metrics, to help explore the impact of echo on a more global level with respect to diabetes care. And finally, I just want to make the point that although we are seeing increased participation globally in the diabetes echo movement, it's still really not enough. And that's a case we want to make today, is that less than 1% of all of the echoes are diabetes echoes. And this is disproportionate when you consider the very high prevalence of diabetes. And I think it's a fair statement to say that probably every one of us in this room are affected by diabetes. We either have diabetes ourselves or we have a loved one with diabetes. And if we fast forward 5 to 10 years, we're going to be seeing more and more diabetes. And one of the strongest predictors of what's going to happen in the future is you look at people who are at very high risk of developing diabetes tomorrow. These are people with prediabetes. 1 in 3 of us have prediabetes, and the most concerning thing is the vast majority, more than 8 in 10, don't even know they have prediabetes. So you can kind of guess where we're headed in terms of diabetes rates. So really, this is a call to action to, if you're at a center that doesn't currently run a diabetes echo, to consider running a diabetes echo. Nick and Maggie are going to share some of their experiences starting their own programs. And perhaps the first step is to join us on one of these. We have monthly collaborative meetings. If you want to scan the QR code and register to meet with us, either you yourself or if you have a diabetes colleague at your center who might be interested in joining us, but we would love to see you. And I think we will go ahead and move on to discussion. And Nick, we talked, I alluded to the Echo Diabetes Action Network, and I wonder if you can tell us what your experience has been developing this network.
Sure. Well, thanks for having me, first of all. And I guess it's been a little bit of serendipity of how it's come to form, and a combination of kind of personal and professional interest in diabetes. And really started after better understanding the lack of care and education and empowerment around diabetes, after meeting a child who was diagnosed with type 1 diabetes in Ecuador many decades ago, which led to starting an organization called AYUDA, American Youth Understanding Diabetes Abroad, which helps communities around the world. And ironically, that the organization that helped fund AYUDA, that you might have heard about yesterday, did David Bornstein's discussion, Ashoka, that social entrepreneurship organization also funded Dr. Arora and the ECHO movement. And then another organization that had funded AYUDA, the Helmsley Charitable Trust, several years, about a decade ago when I came to UNM to work as a pediatric endocrinologist here, I heard that they had just funded this Project ECHO program, and I jumped to reach out to Matt to see if I could get involved and learn more about this Project ECHO program, and worked on the hub team here as a pediatric endocrinologist. It was completely blown away by the power of the ECHO movement for diabetes and addressing disparities and poor outcomes. And then I kind of followed my passion for type 1 diabetes and went to Stanford to help start a type 1 specific ECHO program there in collaboration with Florida, University of Florida, and helped launch some other diabetes-related programming in Ecuador and around COVID, but really became frustrated about the lack of amplification of ECHO programming related to diabetes. And a colleague who was with me at Stanford at the time, Linda Baer, also felt frustrated about it. And so we decided, let's focus more on helping other programs launch diabetes-related programming, as you could see from what the data that Matt shared with you all. And the Echo Diabetes Action Network is a citizen sector-based organization where we are focusing on frontline healthcare professionals, democratizing diabetes knowledge, and really leveraging the ECHO movement and trying to get health systems to start using ECHO for diabetes. And we're trying to promote funding both directly and indirectly to facilitate more launches.
Thanks, Nick. And you've led a very successful network. I'm curious how you kind of got things started in terms of funding. How did that look in the beginning?
I think just kind of serendipity, and you find people who've, for somehow or another degrees of separation, have heard about the ECHO, are really interested in ECHO, and whether it's an industry or private foundations are interested in helping to support. So we don't have huge budgets, but we're going after grants and also trying to encourage other hubs to do the same around diabetes and not to be discouraged.
Thanks, Nick. And Maggie, you created the Whole Person Care for Diabetes ECHO in Oregon. Can you tell me how that came about and how funding has changed over the years?
Sure. So every 2 years, we have a participant interest assessment that goes out across our listserv, and we try to promote it as much as possible. And through this survey in 2018, we found that there were over 40 participants who were interested in participating in a diabetes-oriented program. And so we brought this idea to our Oregon Echo Network Advisory Board, which is a unique program that we created in Oregon that's comprised of Medicaid partners, OHSU, our academic medical center where we're housed, and also a Providence Health System, which is a competitor of OHSU. They all come together to work collectively to support ECHO programs in Oregon. So each year they pay a set fee, and then they sponsor 4 programs. We put diabetes on the ballot, and it was funded. And really why we brought that was it was a leading cause of death in Oregon. And if you look at the number of endocrinologists in Oregon, there were none on the other side of Redmond, going throughout the whole eastern part of Oregon. And if you're not familiar, Oregon's about twice as big as New York State. And so we're talking about a landmass about as big as New York State without an endocrinologist. So we were able to launch our program in 2020. We learned a lot about that experience and offered a couple of cohorts. We changed our faculty makeup over time as we heard the cases, and we found many of the cases were focused on social determinants of health. So we added a behavioral health specialist, a licensed clinical social worker, a community health worker coming from a Latino health organization in Oregon to our group. And in 2021, we went to HRSA, or we applied for the HRSA funding for the telehealth technology-enabled learning program. So we were very fortunate that we received that grant. And through that, we were able to continue our diabetes echoes, but further focus on Latino patients in 6 rural counties. And that program is continuing now. We're going into the 3rd year and very thankful for that funding.
Thank you, Maggie. How has the T-TELP Award affected your programming? Have there been any changes in your ECHO program?
Absolutely. So through the T-TELP funding, we needed to focus on a specific population that needed more support. And so we decided to focus on Latino patients in 6 rural counties in Eastern Oregon. And through that, we also developed for the first time a rural advisory panel. And that has been very successful for us. So that rural advisory panel is focused in those 6 counties where we have physical health providers, clinical health providers, and public health professionals all joining and giving us feedback on the programs we're offering. We're asking them to help promote the programs. And it just, in general, gets us more connected with what's going on in those particular communities. Another piece through the funding that we were able to start again were site visits. And so traveling out to those communities has been crucial for us. And we found it was very successful with our recruitment as well. So if we were offering the diabetes programs before with the different funding stream, but with the new funding, we started doing the site visits, and we were able to see 3 times more participants coming from those counties after we did the in-person site visits. And so I just cannot reiterate how important that was for us.
And just to piggyback off that, with the site visits, if your programs aren't doing diabetes-related echoes right now, typically there tends to be a champion in your spoke sites in the clinic who has diabetes, probably type 1 or an MA or someone there who's really the champion and really trying to find out who that is. That is, in my experience, that has really made those programs really successful in having ongoing spoke engagement.
Yeah, absolutely. And Nick, your program is unique in that you also have helped stand up new echoes. Can you talk more about that?
Sure. So with some funding from industry through Bayer, we were able to award funding to 3 programs to come together as a learning collaborative. So there's a larger diabetes learning collaborative, and then within that we had an RFA where programs applied to do a kind of diabetes specific related to CKD. And so kind of a microfunding, about $75,000 to $100,000 per program to do kind of block content, and really to develop a toolkit to make it easier for other programs to start to implement. So Rutgers, ECHO Colorado, and University of Washington were the three recipients of that. And those programs wrapped up programming this year. We're finalizing the toolkit to make it available to you all on Pearl. And so in addition to some funding, it was also another way in terms of collaboration of a learning collaborative and sharing best practices to help make it easier for you all to implement programs.
And just piggybacking off of that, if there's a diabetes program interested in starting a new ECHO, how would you suggest they engage with the network and pursue that kind of support?
Yeah, I mean, you put up the QR code before, maybe at the end of the presentation, we can throw that back up. But once a month, there's a collaborative, about 100 people on the listserv, about 20 or so programs around the country and a few international who have done or are doing diabetes-related programming. So every month we'll have different topics, and kind of in the spirit of a tele-ECHO session, we'll have a hub team kind of lead a didactic 15 minutes on case presentation forms. And then we'll have kind of collaborative feedback and sharing best practices on whether it be the presentation forms, learner evaluations, funding, et cetera. And so would invite you, if you're thinking about starting a diabetes-related program, would encourage you all to join our community.
Excellent. All right. Well, I want to make sure we leave some time for about 15 minutes for questions. So another question, this is for both of you. Maggie, maybe you can kick this off, but what lessons learned would you like to share with people attending today?
I think it's very important to reach out to your participants and understand and know what they're looking for, because we saw a real mix of what we were hearing. There were some providers who wanted to hear more about medications, and then there were other participants that wanted to address more of the social determinants of health oriented cases. And so we really needed to make sure we were doing our best to address both through our hub team and our curriculum. And so it's about getting to know your participants and being willing to shift over time as well as things change.
Lessons learned, I think the ECHO model is ripe for diabetes, and it's time to get on board. And if you look at how the ECHO movement came along with Hep C, there's just so much overlap with diabetes. When you look at lack of specialists, where 90% of people living with diabetes receive their care in the primary care setting, and that's in the U.S., even less so in other countries. If you look at sweet spots for ECHO of FQHCs, where in general in the US, 1 in 10 have diabetes. In FQHCs, the rate tends to be double that. In some of your clinics that you work in, it might be quadruple that. And so there's such high needs in terms of supporting the primary care setting. If you look at outcomes, we, as Matt shared, we have dismal outcomes. We're in some health plans, we're in over less than 50% of people are meeting A1C targets. We can't say it's patients as non-compliant. This is a system non-compliant, system failure. And then you look more at outcomes and you see the disparities in outcomes amongst races of African Americans more likely to have complications and from type 2 diabetes, and Latino populations, et cetera. I kind of question your all's programs are doing multiple ECHO programs and not doing diabetes programming ethically in the spirit of ECHO. How can you not do a diabetes-related program? So I'd encourage you to think that over.
Could I add one thing? I know that a barrier, often folks will say, well, I'm looking for funding. And I just want to encourage folks to get to know the staff at your local state health department. Often, state health departments get large federal grants that could be coming from the CDC that focus on diabetes, and they are looking for effective ways to be able to deliver programs. And so find those folks and make sure that they know about ECHO, and you really could have a great partnership.
Thank you. I'll answer that one as well. I think one lesson learned for us is just the impact that including community health workers in your ECHO can have for a diabetes ECHO in particular. It's very much a self-managed condition. So as a diabetes specialist, I can give all the recommendations I want, but if the patient isn't activated to implement those recommendations or to make those lifestyle modifications, you're really not going to see any change. And so we've found tremendous impact from including community health workers. They're very well equipped to activate patients. They're trusted by the patients. They're in the communities where the patients live and kind of serve as a liaison between the primary care clinician and the patient. Also, I would say also in terms of just educating the ECHO network too, helping us realize how the recommendations that we give are actually implemented in the real world in the context of what available resources there are in the community.
Yeah, and to add to that, I mean, I think, the diabetes-related ECHO programs, they tend to be the most, uber multi-professional interdisciplinary type of hub teams. You can see from the pharmacist to the endocrinologist to the community health worker, behavioral health. We just had a panel up here, and all those voices are so integral, and it's so efficient where the learners are really appreciative of having all the people in the right place at the right time, and that community health perspective or an advocate for someone living with diabetes, it really just plays such a tremendous role in these programs.
All right. Well, how about for the next 10 minutes, let's transition to Q&A. What questions do people have for us? Questions or comments?
Oh, 2 inches. Thank you. That was the 2 inches. Okay. Thank you. That was really informative and interesting. And as I mentioned to Matt yesterday, with my colleague Martha here, we run ECHOs for community health workers specifically on diabetes. And they're all Spanish-speaking community health workers. So I had a comment and a question. I wanted to know if the work you did in Oregon was in Spanish, because one of the most common pieces of feedback we get from our community health workers is, thank you for providing language to me, education to me in a language that I can understand and that my patients speak. So you've given me not only knowledge tools, but also language tools that help me communicate with my patients who have, as you know, low health literacy and limited English proficiency. So I wanted to know if in your outreach. And then the other thing is towards what Matt said at the end is that we have a lot of tools out there for diabetes now, but unfortunately for the uninsured or the underinsured, we don't have those tools, with the exception of the new financing on drugs, which included Januvia. Some of those medications are not available. And so one of the challenges our community health workers face is that they hear and they learn about all of these drugs and continuous glucose monitors, but their patients only have access to metformin or glipizide, and so they're not being managed to the standards of care that you showed at the beginning. So that's been a challenge that our patients have talked about with frequency, and I want to know if you could comment on that. I mean, our participants have talked about that.
I'd say just as in practice, where people underinsured who come to me who aren't part of ECHO, I think that's one of the things that even as a provider, I struggle with. But one of the things that I've seen in ECHO programs is through the linkage to the hubs. where some of these spoke sites might not typically get donations of free CGMs to give out because of the connections they have to the hub teams. You'll have field reps who are now giving out free samples of SGLT2 medications, GLP receptor 1s, insulin, CGMs. Not to say it's so sustainable, but there can sometimes be kind of emergency relief that way. And there's also another organization called Insulin for Life USA, which helps with kind of emergency type supplies with that. And so they've also donated to some hub programs before for the hubs to then distribute to the spoke sites to help with those type of situations.
And so to answer the question about our programs in Spanish, not right now, but I just wanted to make it clear that our audience for the programs are primarily for primary care providers and their teams, and we have the community health worker on the hub team to bring that perspective. But I am absolutely taking your comment, and I think that it's, especially if we want to be offering programs specifically for community health workers, we should keep that in mind.
And you raised a really important barrier around access to new medications that are very costly. And I can only speak from the New Mexico perspective that our Medicaid in New Mexico has been, I would say, relatively diabetes friendly. And access to GLP-1 agonists, SGLT2 inhibitors, if there are indications, has not been that challenging actually. And the network that we're engaging with in our ECHO is primarily serving Medicaid patients. So that barrier is fortunately for us not been too much of a challenge. That said, that we definitely encounter a lot of patients that are being presented are faced with polypharmacy, and they're making a lot of co-payments for medications that might not be necessary or might lower the glucose a little bit, but it isn't necessarily doing anything from a cardio-renal protection standpoint. So a lot of the recommendations that we're giving are kind of streamlining simplifying the medication regimen. So yes, they might be on a newer medication, but they got rid of 2 or 3 prescriptions to make room for that. All of that said, I think we severely underutilize lifestyle modification as a treatment. And I think that's why what you're doing, the work you're doing with community health workers is so important and something we are happy to emphasize in our ECHO as well. Thank you. Other questions?
Hi, thank you for this great panel. So you've convinced me there's a need that ECHO can provide us a solution, and you've kind of made a desperate call for people to do this and a moral call for people to do it. And I'm just wondering, I'm not an endocrinologist, so you don't want me to start an ECHO, right? But I want to help, right? So I guess, what's your dream? Like, what, in 5 years, best case scenario, what do you want to see? What's the opportunity here? What would make a difference to change that really depressing parallel lines that you have?
I would like to see at least double the number of diabetes echoes that we have now. If you're here and you're at a center that doesn't run a diabetes echo, but you have connections to the endocrinology division and want to discuss this with them and maybe connect them to our collaborative, we would love to work with them to help support that. But I think with ongoing growth of the ECHO, the diabetes ECHO movement, we can help support overcoming therapeutic inertia by supporting implementation of complex guidelines that have evidence-based guidelines, but have been difficult for many people to implement in real practice without further guidance.
Yeah, I'm on that, and I'd say, look, if your program is operating, everyone's different, but there's some ECHO programs there. It's led by a champion, one specialty, and you just have one program in terms of expanding implementation to other other specialties, it's challenging. But if you're a place who's running 5 or more, 3 or more programs, and you don't have diabetes, I would, by next MetaECHO, I'd hope you'd be joining the conversation with us up here.
And I would say, reach out to your participants. My guess is they want a diabetes echo. They need help in this area. And so do it for your participants, but also do it for the patients that need it. And also realize that you have a community that you can reach out to. The Endo Collaborative is fantastic, and you don't have to do it on your own. You have a great place to start, and so just go for it.
Yeah, and with diabetes in terms of the marketing, I think experience that we've heard from the collaborative, when everyone deals with diabetes, but when you're marketing it as kind of complex diabetes, there's a real interest with that. When you're able to leverage it with, CKD and or insulin management, or your behavioral health stuff, it just really, the participants really, wow, that's like my panel. When the majority of them have at least 20 to 40% of patients with diabetes in their panel, it becomes very relevant.
Any other questions? I think we have one over here. All right.
Hi. Thank you so much for the talk. So I learned a lot. I really don't know much about diabetes, but like you said, I know people with diabetes in my family and my friends. So I have kind of two questions in one. I was really interested in what are the main barriers. So you talked about community health workers not being included, to talk about lifestyle changes and then language and insurance and all of that. So I was wondering, what are the other barriers for implementation, since you have all this evidence of best practices that are not translated on the ground? And I was also thinking of outcomes. I was wondering what patient outcomes would be interesting to measure. So for instance, you talked about lifestyle changes, right? So I thought about it as like mediating outcomes, to achieve what you want. So I was wondering if it makes sense to look at the impact of ECHO on lifestyle changes for the patients. So, thank you.
Thank you so much. Those are great questions. I'll start with the first question. And I think nationally, part of the reason for the therapeutic inertia we're seeing, the lack of movement on improving outcomes, is not just uptake of the increasingly complex guidelines, but an underappreciation of what it means for a patient to be living with their hemoglobin A1C 9%. And just not seeing that as a trigger to every 3 to 6 months, if your patient's not meeting their individualized goal, to help them achieve that goal, do something, change something. And we certainly noticed that this is what we observed when we were starting our echo. We initially were calling it a diabetes echo, and we found that most primary care clinicians weren't as interested. They said, we already know how to do diabetes care. We're doing a great job of it, and so forth. So we sort of pivoted and called our echo endo echo, and we sort of attracted people in like, oh wow, you're going to be talking about thyroid disease and pituitary disorders and so forth. Once they became engaged, they quickly realized that there's a lot I didn't realize I wasn't doing with diabetes care. And I think that was another lesson learned. That's a way to engage the community. And now it turns out that even though we're called endo echo, the vast majority, 90% of the cases presented are diabetes cases. So it's sort of transitioned back to a diabetes echo. But yeah, the answer to your question is, I think there's an underappreciation as well of the implications of not doing something to help patients achieve their goals.
Yeah, and then from an outcome perspective, on the last panel, we heard a little bit about that, but I think there's enough outcomes out there on diabetes echo-related programs where we don't need to prove anymore. We just need to start doing it. Not to say we shouldn't continue to monitor outcomes and look at additional data and outcomes and continue to improve. But there's enough out there to make the compelling case, in addition to the moral case, that we should expand this.
Anything else you would add, Maggie? That was a great question. Thank you. I think we're at about time according to our timer, but if there's one more question, we'd be happy to take it. Otherwise, I'd like to thank everyone for attending today. Big thanks to our panelists, Nick Cutress, Maggie McLean-McDonald, and hope to see you on the collaborative calls. Thank you.